My name is Dr. Kimberly Noel, and I'm the Telehealth Director. Good morning. I want to share a very important message with you today, and that is that telemedicine is a big deal. And more importantly, that telemedicine at Stony Brook is possible, valuable, and when executed with the best minds, can really transform the way that we deliver healthcare. And I'm going to start with a spoiler alert for those of you who have been waiting patiently for the clinical trial results that I'm about to share. And that is that our clinical trial had 100% patient satisfaction and 94% medication adherence and 93% adherence to daily checks of blood pressure, pulse, oxygen saturation, and weight. And for the clinicians in the room, we can imagine how challenging it is to get our patients to do what we need them to do to care for their health care. And we've learned a great deal through this trial on how to deliver a service that is absolutely necessary. I want to talk about telemedicine in terms of the times that we're in right now. A lot of people say, well, telehealth is often defined as video chats between doctors and patients, and many a disgruntled physician will say they see enough patients already, they don't need to see more. However, telehealth is much more than that. Telehealth has the ability to optimize technology and help us deliver healthcare across geographic, logistical, and resource barriers. And I dare say, paired with computer science, is probably the most democratizing tool of healthcare delivery in our times. And for those of you who are actively avoiding the news, which these days I call that self-care, it's important to realize that telehealth is bipartisan. We have had so many acts fly through in 2017, and these changes are at the forefront of how we're getting reimbursed, and we need to stay ahead of the game. And we've reached a point of no return in terms of the themes that Dr. Saltz talked about with artificial intelligence and machine learning. And it blows my mind that the cell phone that I hold in my hand has more computing power than what NASA had to send man to the moon. And when I don't use it as an amazing telehealth device, you can use it for blogging, vlogging, shopping. And that brings me to my point, is that industry is moving far ahead of the medical field. And we can't allow that to happen because we need healthcare that prioritizes outcome over profit. And through this trial that I'm about to show you, we'll show how those outcomes were manifested. And I personally got to be there for my patients when they needed clinical care. And some of them attributed that care to saving their lives, and that's still the greatest honor that a doctor can have. So I'm going to start with my humble beginnings, starting this trial as a resident with a $10,000 budget allocated from our Chief Information Officer, Dr. Gerald Kelly, and tell you the story of how that manifested in training over 18 physicians in telemedicine and really blossoming telehealth activity for the institution, signing all of our patients up to the RIO, to the Regional Health Information Organization, and hopefully paving the way of telehealth for many years to come. When I think about telehealth, I like to break it down into buckets of hardware, software, and clinical workflow. But the most important piece is the data, how we collect the data and how we use the data, optimizing the use of the internet. And as I mentioned, we're now in an era where artificial intelligence and robotics, wearables, and predictive analysis are skyrocketing. And to give you kind of a sense of this, it's one of my favorite videos. This is a video from Boston Dynamics. When we think about telemedicine, it actually started with funding in robotics from the Department of Defense. And the goal was to create robots that could help stabilize troops in the battlefield. And when we think about how far that's come, it's really quite impressive in terms of technology. We also are seeing telemedicine at the forefront of our natural disasters. We're pretty lucky that it's not hurricane up in New York, but many of the large telehealth providers have provided assistance for Hurricane Florence. We now have a new Apple Watch 4. I don't have one yet, but apparently it can diagnose atrial fibrillation, and it has an FDA-approved EKG machine. And there are new players in healthcare that I mentioned before, but ones that we can't ignore, such as Amazon, Berkshire, JP Morgan, Google, Walmart, Uber. They're really taking the reins, especially in the ambulatory world, of providing healthcare services to their own employees, and that will be disruptive to primary care. So a couple of terminologies that you should be aware of. The trial that I'll talk about in a minute is an example of remote patient monitoring, and that's basically the ability to collect data, patient data, over geographic barrier. So in this case, we were taking patient vitals, but data can be obtained through many different things. And just to give you a sense of what kind of momentum the market has had, you can now take EKGs from the tip of your fingertips, not only from your watch, but there's also continuous EKG patches. And of course, the fitness, we're all aware of kind of the developments in the fitness realm. And we now have the ability to do a complete physical exam through HIPAA-compliant means with small, multi-purpose devices that are quite impressive. And you can put so many different types of scopes on your mobile device, which really makes almost a better documented physical exam in certain cases. Another exciting area of growth is in biosensors. So the first FDA-approved drug was actually for schizophrenia, which I didn't think was the best potential case use, because the sensor is supposed to help activate. When you swallow a pill, it has a small chip that interacts with a patch, a dermal patch, and that allows for you to track adherence. So oftentimes with schizophrenia, patients, when they have problems with adherence, can become destabilized, and we need to, there are concerns about their geographic location. And so the idea of the pill was that if we could help track adherence, when they start missing doses, we can activate their care team to mobilize them. However, if you're paranoid that people are watching you, or maybe, maybe that wasn't the best use case, but digital sensors have really taken off in multiple different industries or different specialties, and the goal is to be able to help patients monitor their own adherence and involve their physicians. You can put sensors anywhere, and I do mean anywhere. There's also smart clothing. So it's pretty exciting if you ever go to a telehealth conference to be able to see the latest in technology. So as I mentioned, I think telehealth is one of the most democratizing tools of healthcare. And now I'll talk about the initiative that we had at Stony Brook here, which was really a multidisciplinary approach involving a great vendor, Vital Care Services, as well as our family medical group, our care management inpatient, led by Dr. Feldman, our hospital physicians, as well as an advanced study team through biomedical informatics and the Department of Population Health, Family Population Preventive Medicine. So this study was theoretically based on an idea that patients, well, we know through the literature that the most challenging time for patients are often after hospital discharge, and it could actually be quite unsafe if patients have changes in medication where they don't know how to self-manage or they don't understand the purpose of their medications. especially if they don't have a follow-up appointment with a primary care doctor, if they're unaware of their red flags of symptoms, and also if they don't have a centralized access to their health record. And particularly, this is really important for the clinicians that are taking care of them. So Eric Coleman developed these 4 pillars that basically identify if you do these 4 steps, then you can reduce adverse events and potentially reduce readmissions. So we decided that we were going to do this in a legitimate way, design a high-quality study that we would have tracked on clinicaltrials.gov and the World Health Organization trial registration to be able to ask the question, can we provide tele-transitions of care? And we took the first month after hospital discharge, and we were planning to do biometric monitoring with blood pressure, cuff, a pulse oximeter, a scale, and test these population health risk stratifiers, as well as do weekly visits with patients to make sure that to deliver health care. And we included patients age 30 and older who are English speakers with good cognitive function, who are able to consent, not at the end stage of life, so no patients on the palliative care service, and with a disposition to home after hospital discharge. We worked very closely. One of the strengths of the trial was working with the primary care physicians directly, so that we did not create another independent service of care. And so in doing so, one of the exclusion criteria was the uninsured, because we took patients that were already plugged into the family medicine practice. So we were able to assess 451 patients and randomize 105, and allocated 47 patients to the treatment group and 58 to the control. We were able to enroll patients at the hospital bedside and consent them prior to discharge. And through that randomization process, when you do research, you like to see that the treatment and control groups, that the randomization worked. And I'm happy to say that we have no statistically significant differences among the treatment and control group. We had a similar breakdown of age, gender, education. And this is pretty reflective of the population of Suffolk, I would say Suffolk County in general. Notice that a large population is unemployed, which is reflective of potentially the hospital population. It's pretty hard to work when you're sick. And a significant number would say that their health was fair or poor, which is again reflective of the hospitalized population. We also did tests of technical aptitude, asking them how comfortable they were with the technology, and they were both equally fairly comfortable. What was really interesting is around 95% of patients have their own cell phone, and really a smartphone, and 98% have internet in their home. So this is really a kind of exciting show of our times that technology is in fact developed. These are not the incredibly techy population, although we are consenting people for a telehealth trial while they're hospitalized, so they're probably more inclined to technology than the average patient, but they spend about 4 hours on a computer when they do use a computer. The patients are quite sick at Stony Brook Medicine. We had about 12 diagnoses in each of the groups, and about over 3 clinicians, specialists involved in their care at the time of discharge. They're discharged with about 11 to 12 medications, and their time to first primary care appointment was 16 to 19 days. A lot of them, a significant amount, were discharged without a follow-up appointment to their primary care. It's over 50%. And the readmission risk score is correlated to the percentage of chance of readmission, was 45% on both sides. So the patients with the highest risk were also about, I'd say, 37, 38%. And that's important because of the diligence of work that we had to do when we were delivering care. So for the treatment group, as I mentioned, they are quite sick. And so when you think about delivering telehealth, you have to do it in partnership with about 3 different physicians and making sure that medicine reconciliation is done on 12 different medications, assuring that the patient has refills and there are no errors, no duplications, and we really had our work cut out for us. This is an example of the telehealth kit that we gave. And as you can see, it's pretty rudimentary. All of this is widely available on the market, but all FDA-approved devices. So when we ask them, so if you think about it, we have patients of all age groups, and we're asking them to log on to a tablet and take their blood pressure every day and their pulse oximetry every day and weigh themselves. And when we asked them how difficult it was to participate in this study, they actually said it was really easy. And there's no statistically significant difference between the control group, where all we did was ask them a bunch of questions in a survey at 30 days, and then the people who were really doing weekly visits and taking their vitals daily. We had a statistically significant improvement in enthusiasm for those who participated in the study, and they were confident that telehealth helped their healthcare. And that was also strongly statistically significant. We were able to maintain the satisfaction over the entire course of the study. They were incredibly satisfied with the technology, which is interesting because we did have a few hang-ups. It's not always so easy to follow the prompts for these medical devices. We've had 100% satisfaction every time. And as a clinician in the trial, it was very interesting that the patients wanted to involve their families, oftentimes wanted me to establish care over a longer period of time, and that was really wonderful. To show this data a different way, you can see that on the left they're saying, we asked them, how satisfied are you with the technology? And on the right, we're asking them how have you had difficulty with the technology? So in week 1, 33% of the patients had difficulty with the technology. Week 2 was 27%. Week 3, up to 40% of the patients had a problem with the technology, and yet their satisfaction scores were sky high. And when you look at the medication adherence, we had 94% medication adherence in week 1, 97 in week 2, and by the end we had 100% medication adherence. And we're having a lot of health events throughout this time. If you see on the far right, we had 25 to 36% of patients exhibiting health events, and a lot of medication changes, which is also reflective of this post-hospitalization phase. So to give you an example of the value of telemedicine, this is a patient who was seen in the outpatient actually several times concurrently with our telehealth service. For the non-clinicians in the room, I'll point out, so this is the aorta. This is the main blood supply to your entire body. You're not supposed to have a big tear in this aorta that is displayed right here. You're also not supposed to have this big fluid collection in front of the aorta and the heart. And this is an aortic graft with the glue they use surgically to repair an aortic graft. So this patient was hospitalized. This surgery happened a long time ago, and he was hospitalized because the graft had become infected. And when you see this gentleman, he looks great. After he was discharged from the hospital, you would never suspect that he had had such an invasive surgery. And as in primary care, oftentimes, not every exam are you reviewing the radiology history of a patient. But because of the telehealth trial, we did, and it was really important to realize that you don't want to put too much pressure on a graft like this. The goal of this is to keep the patient's blood pressure quite low without the patient exhibiting symptoms. And we started seeing these bumps, 130/91, which wouldn't really necessarily make, for the average patient, a doctor very stressed out. However, we kept seeing these high diastolic values, and this was a simple fix. We just increased his dose of his medication, of his blood pressure medication, and we were able to monitor him for 30 days, and he did great for the entire time. And so this is an example of how minor titrations and specialized focus over time can really give us new information. So 94% of the patients said that the technology was helpful in managing their needs, and 98% said that they wanted to continue using the technology to manage their healthcare, and 100% said that it was valuable. The goal of this was also to look at utilization, and although our sample size wasn't large enough to detect a reduction in readmission, we were able to see a statistically significant decrease in emergency room utilization. And I'll explain why readmissions is not the end-all be-all for these patients and for evaluation for telehealth services. Telemedicine is primarily a communication tool and management tool. And we do see patients that are quite sick. So this is a gentleman that I had taken care of who had a rare condition called dermatomyositis. And as you can see here, he had a lot of swelling of his lips. And he was discharged from the hospital without symptoms of issues swallowing. But that had progressed, and over the first week, he really became quite swollen, and we were concerned about his airway. And so that was an emergent transfer to the ED, but in a coordinated fashion in which we were able to notify the team prior, and he was admitted to the ICU within less than an hour of our telehealth encounter. We had a patient who stroked during this trial. This is a patient who is very challenging, and we were able to improve her self-detection of symptoms where she was actually able to get to the emergency room on time. And although she exhibited no alarming blood pressure changes or heart rate changes, and she was quite adherent to her medications, she knew that something was wrong. And through our counseling, weekly counseling, we had prepared for if her symptoms were to decompensate. And so she knew exactly when to seek care. We also have a patient who had a very end-stage COPD, or I'd say, I wouldn't even call it moderate, I would say really severe COPD, who was originally in his first hospitalization sent home without oxygen, but through our oxygen monitoring, he started to dip into the 70s. And that prompted us very quickly to transfer him to the hospital in which he was admitted to the ICU. And so my point is, for the non-clinicians in the room, these are the lungs, and oxygen is supposed to flow throughout the entire, through the entire organ tissues. But if you can see here, this is walled off. So this whole area of the lung is not getting good ventilation. And so oxygen monitoring for this patient actually became life-saving. So these are the words of our patients. And again, this speaks to how important this technology is. With that, I'd like to introduce a colleague of mine, Dr. Erin Holfish, who is a critical care physician in pediatrics. And she's helping us develop telehealth technology to evaluate patients transferred from the community or from a community hospital to Stony Brook. And she's been instrumental in helping me with telehealth education. So I'll let her talk about this.
Thanks, Dr. Noel. Good morning. My name is Dr. Erin Holfish. I'm one of the assistant professors of clinical pediatrics in the Division of Critical Care Medicine. I'm also one of the telehealth coordinators for education. Since joining Stony Brook, I have really been passionate about bringing telehealth to pediatrics, and not only to pediatrics, but to our entire hospital. And being able to do this and working with Dr. Noel and the telehealth work group has been an amazing opportunity. One of the things that we worked on very arduently over the past several years is how do we bring telehealth education, because we don't want everybody just going out into the community and doing everything on their own. We want to be able to help them and counsel them on some of the correct ways of getting telehealth, and what are some of getting telehealth to their communities, and what are some of the applications that can be used in telemedicine. So Dr. Noel and I developed the Telehealth 101, which we started as a grand round series. We presented it to many different departments: neurology, psychiatry, internal medicine, general surgery, and then my own department, pediatrics, just this February. So and the feedback we got from all of these sessions were amazing. How can I participate? The participation in our telehealth work group started growing by leaps and bounds. Everybody had ideas. They saw the potentials of how telemedicine can bring our community together. How can we, as clinicians, help by using the technology that we have today to be able to expand to our community, to be able to expand to our hospitals, be able to expand to other hospitals in our community in order to provide the best patient care. And many ideas have come forth. All of them are being worked on, and we have several that are about to be off the ground. And it's due to our efforts and our whole team that we've worked on to be able to spread the word of what's going on. We've also developed several different courses, some of which are ongoing right now. We have we've been working with many of the different schools of medicine, all 6 of them, to be able to bring everything together to really create a multidisciplinary approach to telemedicine and telehealth, and what this means to each department. How are we as a community going to bring this all together? What does it mean to a nursing or social work? How does this work? This afternoon, you're going to get a flavor of some of the things that we have to offer within this course, within the courses that we've developed. Dr. Fabus will be showing some of the interprofessional skills that she has been working on with the School of Social Work and Healthcare and Pharmacy, and how we can use this technology to work together to bring the health of the patient. And then this afternoon, we'll also be going over different cases that we use in the medical student courses that we have developed. So we have several different ones. One is a selective from the medical school that we've done through both the first-year class and the fourth-year class to be able to demonstrate some of this technology. They're interactive workshops where we have a mix of both didactic sessions with experts from around the field, as well as those that are coming from the more interactive side. We've actually partnered with the Simulation Center at Stony Brook for several of our projects, which has been a really, really invaluable tool for us to be able to put this into practice. How can you use this, and how can we teach you to use this in a more standardized fashion so that you know what to do when somebody is in front of you and having what Dr. Noel was able to experience, which was a patient decompensating in front of her. What are you supposed to do? How are you supposed to react? And what are you supposed to do to help that patient? So we have designed several case scenarios, and this afternoon we'll be going through one of them. We've also developed a full week course, full 2-week elective that we have developed for the medical school and expanded to the different schools of medicine throughout Stony Brook, to invite different lecturers to come through and share their experiences, share the wealth of what can be used with telemedicine, and combining those with interactive cases. We've had great feedback from all of these courses and are looking to expand it as we go forward and as we look into the future of what is telemedicine at Stony Brook. With that, I'm going to turn it back over to Dr. Noel to talk about some of the cases that she's developed in terms of chronic opioid management and some of the things that we have worked towards with the telehealth education. Thank you very much.
So we're now using the space in collaboration with the SIM Center to be able to create interprofessional cases to allow for different specialists to provide their clinical advice for patients that don't really fit in one box. And when we deal with, we'll have experts later today to talk about the telepsychiatry initiatives that are moving forward, and I'll just tell you briefly though about our case development for chronic pain and opioid addiction. So there is an actual board that meets for chronic pain, and they came to me and said, well, can we connect virtually to patients? And we have worked on creating this module to be able to train residents on how to use the technology to be able to partake in group management of complex patients. And it's become a great tool to help prepare residents for very, very complex cases in which there are, over 4 specialists or so this is ongoing. We're going to be rolling out our first residency training in, I believe, this winter. And so that's that. And then we've also developed a medical student course called Docs Data and Disruptive Technologies. And this has progressed. Now we're in our 2nd year, and already it's pretty impressive to see that half of the medical students have software they're software developers from undergrad or have engineering degrees. And so we're seeing a quite change in even students who are practicing medicine or are preparing to practice medicine. So if you are interested, I just wanted to leave information to connect with us, whether it be education or the trial or projects. You can email Danielle Pavelka, and we'll help prepare to get your projects to IT governance, and also we'll provide telehealth education for departments and for researchers. And we now have clinician privileges, so we've been able to vet through our legal team that our malpractice policies do cover telemedicine, and you'll hear from our lawyers this afternoon, as well as I wanted to reference our website that is live, in which you will be able to see the latest and greatest in telemedicine. I didn't get a chance. We're going to go into a break soon, but I wanted to open the platform. If anyone had any questions about the trial, I'm happy to take some questions. If not, then we can break. Yes. So what's interesting is that we never had a really formalized budget, so it was actually very thrifty. And we didn't hire any new physicians to do it, so we really optimized our resident workforce to be able to provide these services. I must say that we also had a scale capacity. Dr. Gerald Kelly will talk about the details of the trial this afternoon, so you get a better sense of what the clinical workflow was. But we developed a new strategy to be more efficient in our communication, to be able to integrate the resident management into the attending schedule. So we created a new way to hand off this valuable healthcare information. And we also trained the patients to work with us. We did not say this was a 24/7 around-the-clock service. This was a once daily evaluation of blood pressure. And surprisingly, we didn't have anybody not follow the rules. So I think that resource is a very important question. Telemedicine will cost something. The technology is not free. But we are now seeing the development where these technologies are readily available. So And first, not all patients, the weight we didn't use for many of the patients, and if they had heart failure, and even then, it really didn't change the management. So what do you really need? Maybe it's a blood pressure cuff alone, and you create a program around one aspect of the data that you need to collect. But it does take dedicated time, clinician time, but it can be done. So, yes. So this is a question that is often debated, and one of the barriers in which it has stopped telemedicine from growing because of the concerns about fraud and abuse and increasing cost. But I think that the trial shows that we can do it. We can do it in a responsible way in which we've actually decreased utilization. So for at least for ED visits, and I would argue that those people that we had readmitted really did need to be readmitted. So I think that it is very important that we talk about proper reimbursement for the services. And that is, you'll learn a lot about that also this afternoon in the legal session. But it can, crafted in a well-designed fashion, we can actually give services, the right kind of services to patients. Actually, we have our the head of the company right here, Chris Gore. I'm sure he'd be happy to answer any of the technical things, but I'll answer the question. So just to clarify, we enrolled patients in the study at the bedside. And what we had is we had study coordinators and with clinical training. So we had one MD and one RN who approached the patients, but it did not necessarily need to be for clinical enrollment. The patients were given, when we did the technical aptitude survey questions, we also showed them the equipment, and one of the requirements was that they could turn on an Android device, that they could follow a prompt. And so the patient was introduced to the technology, but not given the technology at that time. And it was early in the course of the hospitalization. So when the patient, we actually worked with the care managers to let us know when the patient went home, and then within 2 days of hospital discharge, the vendor delivered the equipment to the home. And I really believe that our adherence and our strategy was reinforced by great customer service, because being able to come into the home, set up the equipment, do a demo with the family members was a really great warm handoff. And so with that, we were able to get the equipment handed to the patient, and then also there was the service of recouping the equipment. Other vendor services, they provide the telehealth equipment at the bedside. You know, you can discharge a patient with a kit the way that you would discharge them with durable medical equipment, and then they give mail back, you know, like mailing, postage mailing, so the patient can return the equipment. But now we're also seeing readily available equipment that patients may want to purchase. I had a lot of patients who asked me, "Look, you know, can I buy this?" I would say, "No, you have to give it back."